When evaluating a CT of the abdomen and pelvis, it's important to recognize the typical findings following a Roux-en-y gastric bypass, particularly for radiologists who might be interpreting the studies. Oftentimes, this information is not provided, or even for a surgeon who's consulted on a patient who's presenting with abdominal pain or obstructive symptoms. This history might not be readily provided, particularly if the surgery is remote. This review is going to focus on evaluating the bowel with a focus on the postoperative anatomy and most common complications after the Roux-en-y. But obviously, for all patients that have a CT that you're reviewing, you need to make sure that you evaluate all the nearby viscera, since disorders of these organs, such as the pancreas, liver, or gallbladder, can cause similar presenting symptoms. As you scroll down on these images, I've loaded here, there's an axial image that is annotated and one that is not annotated. So as you're looking in your browser, you can feel free to pull them up side by side by changing your layout and pulling over your other series. And as you can see on this, on mine, it's the one on the right side of the screen. I've annotated the different loops, and we'll scroll through and show these to you. So as you scroll down, I'll go through the annotated one here. As you scroll down, you first get to the gastric pouch, and the yellow on this is the alimentary limb, and the blue is the biliopancreatic limb. So it begins at the excluded stomach, which is the portion of the stomach that's been removed near the GJ anastomosis from the alimentary tract. Here is your gastrojejunal anastomosis. This is the first area that you'll note in evaluation for post-op patients. Complications to look for in this area are an anastomotic leak in the early postoperative setting or marginal ulceration, which may occur remotely from the surgery, secondary to non-physiologic exposure of the jejunum to the acidic gastric fluid. These would be evidenced by surrounding fluid or mesenteric fat stranding, which you'll see in one of the teaching cases. Then you can follow the alimentary limb, which is yellow in here, inferiorly to its jejunal anastomosis. In this case, you can see the limb is passing anterior to the colon, which is outlined in orange, and this is making this an anticolic Roux-en-y. Of note, the terms alimentary, Roux limb, and efferent limb are used interchangeably to refer to this portion of the bowel, which can be very confusing. I prefer alimentary because it refers to the function of this portion of the bowel, which is to transport the ingested food through the GI tract, but you will see all three of these terms used by radiologists and surgeons. In this case, the limb is nicely opacified with oral contrast and is mildly dilated. This patient is less than a week post-op from her initial gastric bypass surgery, and so this does not represent an obstruction. This just has a little bit of edema, which is causing the bowel to have a little bit of delayed contrast, but you definitely would want to correlate with obstructive symptoms. In this case, the dilation is not associated with a high-grade obstruction, but you always want to consider your patient closely depending on the clinical scenario. After tracing your alimentary limb all the way to your jejunal anastomosis, then you can trace your biliopancreatic limb, which begins up here at your excluded stomach, which is outlined in blue, and traces down through the duodenum and across, and also comes down to your jejunal anastomosis. Within the excluded stomach, it should be nicely decompressed as it is here without any significant gas or oral contrast. If you see either of those things within the stomach, it can be an indication that there's a leak across the or a gastrogastric fistula between the gastric pouch and the excluded stomach. Distal to the jejunal or JJ anastomosis is the bowel is referred to as the common channel, which is outlined here in green. Continue to evaluate in this area for obstruction or inflammation, which most commonly is going to occur near the JJ anastomosis, but can occur anywhere. Patients who've had a gastric bypass are still susceptible to all the same bowel pathologies which might afflict normal patients, to include appendicitis and diverticulitis, so you need to evaluate for these findings as well. Hopefully these annotated images are useful as you are learning your search pattern. I think a good tool may be to pull up one next to each other to see what tracing them without the annotations and then using the annotations as well to help you understand where the bowel is going and what the postoperative anatomy is.